Okay, my dear colleagues, you are very welcome to our webinar. Before opening the session, I would give a very brief info about Tjod, Turkish Society of Obstetrics and Gynecology. We have more than 5,000 members, and we are very good collaboration with EPOC and FIGO. I think that's enough for our information. Now, we all know COVID-19 pandemic threatened public health very seriously. But there is another reality that the relevant causes brought us much closer to sharing science. In Turkey, COVID-19 pandemic is not going well. I think many countries maybe can be seen. Now, we have very delicate task for today, especially in terms of faculties. Subjects are very difficult and much more complicated than any other. If we are late for diagnosis, we can lose fetus or mother. If we attempt early, mother can give a baby with neurological defects or some other immature organs. All are terrible. In this webinar, we will discuss the detail. Valuable, very well-known faculties are going to share their experience. I thank them a lot accepting our webinar invitation. Indeed, I appreciate their science efforts. And now, before inviting Fonseca as a first speaker, I would like to read his brief CV. I'm saying brief CV. I think we need one session to read my faculty's CVs. Dr. Eduardo Borges de Fonseca received his medical training at the Federal University of Parabia in Brazil and became a consultant in obstetrics and gynecology, registered with the Brazilian Federation of Gynecology and Obstetrics in 1998. He subsequently received master's and PhD degrees from the University of Sao Paulo in Brazil, focusing his research on the causes of prematurity. Dr. Fonseca furthered his research interest with a fellowship at the King's College Hospital in London, working with Professor Nicoloides on the relationship and treatment of cervical length to premature birth. Dr. Fonseca has published several papers, as we know, as we read, on the relationship of preterm birth to cervical length, and in 2003 was the lead author of one of the two key papers regarding the use of progesterone in the prevention of preterm birth. In a recent publication, the paper has been signed out as one of the most memorable papers that J. Lambs has edited during his time as editor-in-chief of the American Journal of Obstetrics and Gynecology. The most important research was published in the New England Journal of Medicine in 2007, in which nearly 25,000 pregnant women were screening for preterm birth, and those found with a short cervical length took vaginal progesterone. During this time in London, his interest in fetal medicine became more evident, receiving training in this field and getting the diploma in fetal medicine by Fetal Medicine Foundation. He is currently vice president of the Brazilian Society of Ultrasound and senior professor in the Department of Obstetrics and Gynecology at the medical school at the Federal University of Parabia in Brazil. And his research interests include prevention of preterm birth, screening and prevention of preeclampsia, screening of fetal abnormalities, and invasive procedure in fetal medicine. He has written 7 books and more than 80 chapters in Brazilian books. Yes, this is your turn, Mr. Fonseca. Please You can take your position at stage.
Thank you, Prof, for your kind words. It's a pleasure to share this session with this team. And I'm going to divide, to split these presentations in two different sets. The first, I'm going to speak shortly about symptomatic patient, and therefore, and then I'm going to speak about the strategies on a symptomatic patient. So, in the preventions of preterm birth, firstly, it's important to understand that the preterm birth is not a disease by itself, but is a syndrome. And it's very important to divide preterm birth into subgroups. The first one is the spontaneous preterm birth that occur in about something between 50 and 75%, and those preterm birth that are medically indicated that occur in about 25–30%. So today, I'm going to speak the prevention, the strategies on the spontaneous preterm birth. And the strategies is based on two different groups. First one, we have a symptomatic patient where it's nowadays is important to have the right identifications of the risk factor. And we have at least three important risk factors that need to be understood. And for that, we have such different treatments. Prior history of preterm birth, twins, and short cervical length at mid-trimester scan. In the group of symptomatic patients, the most important thing is not to discuss about tocolize, is not to discuss about steroids for lung maturations that we know that has an important role in this scenario. It's not only important to discuss about magnesium sulfate for neuroprotections or antibiotics for GBS or antibiotic for a specific group, but the most important thing in this subgroup is the identifications of the true preterm label. Most of patients that goes to the hospital in preterm labor are not in true preterm labor. And maybe a good way for the identifications is by cervical assessment and or fetal fibronectin. Through these two management, I can select a better group for interventions and hence decrease the internation or what means I'm not going to have unnecessary internations. I'm not have unnecessary medicalizations. I'm not going to use steroids or magnesium sulfates or antibiotics in a group of patients that is more likely to have a term or at least that is not going to deliver in the next 7 or 14 days. So in symptomatic patient, identifications of true preterm label is the most important thing, and I can do either by cervical assessment at the moment of the patient come in to the hospital or by fetal fibronectin. But today, I would like to focus in the identification of the risk factor in a symptomatic patient. So select a high risk group of symptomatic patient, and the three risk factors are the most important factors, and then to discuss which treatment I can use. We don't know that through this meta-analysis published in 2013 by the group of Cochrane, where 36 RCT was included, more than 8,000 patients, more than 12,000 infants. They demonstrate that progesterone versus placebo for women with a prior history of preterm birth is associated with a reduction in the rate of preterm birth, less than 34 weeks and less than 37 weeks. There was no differential effects in terms of route of administration, time of chemotherapy, and dose of progesterone for the majority of outcomes. And nowadays, we know that 17-hydroxyprogesterone doesn't work as good as we imagined in the past. And there is, let's see, an advice from the FDA that this drug shouldn't be used in patients with prior history of preterm birth because there are side effects, and the result was not that good, was from the first study published in the New England Journal of Medicine by Pomies. So we know that the progesterone versus placebo is good for patients with past history of spontaneous preterm birth. There is a reduction in the rate of preterm birth. There is a reduction in the birth weight. There is a reduction in the need of ventilations or admission to neonatal intensive care. And progesterone is good as well, according to this meta-analysis, in patients with short cervix identified on transvaginal ultrasound. And there is suggestion that it could be used in patients with other risk factor, including preterm labor. But I would like to discuss today more about 3 weapons that we have for prevention of spontaneous preterm birth. We have progesterone, we have pessary, and we have cerclage. And here, it's not questions what is the best treatment, but the question is to find the right patient for the more effective treatment in order to reduce the rate of spontaneous preterm labor and decrease the rate of neonatal, the severe neonatal outcomes. So I'm going to focus in 3 risk factors: prior history, twins, and short cervical length. But I'm going to concentrate the discussion in short cervical length. Why? Firstly, because it's the best way to compare those 3 treatments. And secondly, because the cervical length is the most powerful predictor for preterm delivery in the current pregnancy. So it's very important to ask for each patient that I have in my office if the patient has or not a short cervical length. And taking account this advice, we suggest, according to FIGO statement, that every single patient should have a cervical assessment. If the patient has no prior history of preterm birth, singleton or twins, the cervical assessment, transvaginal scan at anomaly scan. If the cervix is longer than 25 millimeters, routine prenatal care. If the cervix is shorter than 25 millimeters, vaginal progesterone is the right indication. For those patients with singleton and prior history of preterm birth, I'm going to follow the cervix from 14, 16 weeks to 24 weeks, according to the prior history of preterm birth. If the patient had a very, very early preterm birth, less than 24 weeks, there is a high chance of incompetent cervical insufficiency, and then the cervical assessment should start at 14 weeks. If the preterm birth occurs between 28 and 36 weeks, the cervical assessment should start at 16 weeks. And if the cervix is longer than 30 millimeters, I'm going to repeat the cervical assessment every 2 weeks up to 24 weeks. If the cervix is less than 30 millimeters, but longer than 25 millimeters. I'm going to repeat weekly up to 25 weeks. And if the cervix is shorter than 25 millimeters, I'm going to indicate progesterone and discuss about cerclage as well. But what does means short cervix? This is the question in these moments. Well, I can use softwares that you can download free from the internet and put in account demographic maternal characteristics, height, weight, and the cervical length, and then to find a specific risk for preterm birth, or I can split patient into groups. No risk factor, short cervix is defined as less than 20 millimeters. In a patient with prior history of preterm birth, twins or triplets, the cutoff of short cervix is 25 millimeters. So I'm going to put here two cutoffs: no risk factor, less than 20 millimeters. If I find one risk factor, either prior history, twins or triplets, the cutoff is 25 millimeters. And in nowadays, when I have a patient with short cervix, and I think if I'm going to get progesterone, pessary, or cerclage, I have to take in our mind, we have to bear in our mind that I'm going to have three different kinds of patient with short cervix. Either no prior history of preterm birth, or I have twins with short cervix, or I have patients with prior history of preterm delivery plus short cervix. And now I'm going to try to understand the best treatment, progesterone, pessary, or group of twins. However, in a subgroup of women with a short cervix less than 25 millimeters, vaginal progesterone reduced adverse perinatal outcome from about 43%, and the author's conclusion was vaginal progesterone may be effective in the reduction of adverse perinatal outcome in women with a cervical length of or less than 25 millimeters. Of course, we need RCT to confirm these findings. Later on, in 2007, Roberto Romero brought this meta-analysis published in the White Journal, where 6 RCT with 300 women and 600 infants demonstrate that vaginal progesterone prevents preterm birth and neonatal morbidity and mortality in women with twin gestations and short cervix equal or less than 25 millimeters, and the reduction was about 31%. The conclusion from this paper was that vaginal progesterone to symptomatic women with twin gestations and mid-trimester short cervical length reduce the risk of preterm birth occur at 30 to 35 weeks, reduce neonatal mortality and morbidity as well. So this is the conclusion that we have so far. And just a couple of months ago, the group of fetal medicine brought this wonderful paper published in the American Journal of Obstetrics and Gynecology, named Early Vaginal Progesterone versus Placebo in Twins Pregnancies for the Prevention of Spontaneous Preterm Birth, a RCT, a randomized double-blind trial. In this study, about 1,100 patients was split to have vaginal progesterone 600 milligrams or placebo from 11-14 weeks up to 34 weeks. And the primary outcome was reduction in the incidence of spontaneous preterm birth between 24 34 weeks. So in this study, 596 patients received 600 milligrams of progesterone and 598 patients received only placebo. And the rate of preterm birth was quite similar in both groups, 10% in the progesterone group and 8% in the placebo group. Post hoc analysis has that progesterone could had a good benefit for patients with short cervix, less than 30 millimeters, for birth less than 32 weeks. But the most important is that progesterone for women with twins and cervix longer than 30 millimeters could have a bad benefit and could be harmful for the patient. So the conclusion of this study was in twins, vaginal progesterone did not reduce spontaneous preterm birth in unselected populations. However, post hoc analysis lead to the suggestions that progesterone may reduce the risk of spontaneous preterm birth less than 32 weeks in women with short cervix less than 30 millimeters, and it may increase the risk for those with cervical length more than 30 millimeters. From this study, what we learned? First, we need RCT in patients with short cervix and twins. I know that is difficult because it's quite difficult to get patients for that nowadays. And secondly, we couldn't, or better, you must not use progesterone for every single twins, because for those with long cervix, there is suggestion for not benefit, and even worse, progesterone in patients with twins and long cervix could be harmful. And what about pessary? 2016, again, FMF group in a wonderful study with about 1,000 patients in a select population of twins demonstrate that pessary doesn't work in twins, and in a subgroup of 214 patients with short cervical length, there was no difference in pessary in pessary and no pessary in this group. Actually, in the group of pessary, the risk of preterm birth less than 34 weeks was about 31% in the pessary group and 25% in the control group. And there was no difference in the length of the cervix. The pessary doesn't work in a very short, in a middle, or in a long cervix. And the conclusion of this study was in twins with any cervical length, insertion of pessary at 21-23 weeks does not reduce the rate of preterm birth, does not reduce perinatal death and mortality, perinatal death and neonatal morbidity as well. In the same journal, at the same time, the Barcelona group, by the leadership of Maria Goya, brought this paper where cervical pessary was used to prevent preterm birth in women with twins, 138 women in short cervical length, less than 25 millimeters. In this study, the conclusion was that the insertion of cervical pessary was associated with a significant reduction in the spontaneous preterm birth rate from 39% to 16%. And when you put everything together in this meta-analysis published in the Black Journal by Gabriele Saccomi in 2017, 2 studies, 3 RCTs, 481 patients, 606 infants, 2 studies with the rate of preterm birth less than 34 weeks, there was no reduction in the rate of preterm birth, and the conclusion was Arabian pessary in twins with short cervical length at 16 and 24 weeks does not prevent spontaneous preterm birth or improve perinatal outcome. Of course, RCT are needed to clarify the study's conflicting results. Why in the Barcelona group works, why in the FMF group doesn't work. And later on, I'm going to try to answer this question. And what about cerclage in twins? We know that there are 3 papers and they were put again together by Gabriele Sacconi and Vincenzo Berghella and was published in 2015. In this small meta-analysis, they demonstrate that cerclage doesn't prevent preterm birth in asymptomatic twins gestations with a maternal short cervical length on transvaginal ultrasound. So even in patients with twins and short cervix, cerclage doesn't work. Actually, cerclage increase the risk of preterm birth less than 34 weeks in 2 folds. So to use cerclage in twins in short cervix is harmful. And what about singleton? Progesterone, pessary, or cerclage? First study, pessary, published in The Lancet 2012 by the Barcelona group, has demonstrated a reduction from 27% to 6% in the rate of preterm birth less than 34 weeks in those who received pessary. And the conclusion was pessary prevent preterm birth in a population screened for cervical length at the mid-trimester scan. Again, a few years later, 4 years later, published in the New England Journal of Medicine, about 1,000 patients with cervix equal or less than 25 millimeters were split to have pessary, 466 patients, versus expectant group for 469 patients. And in this study published by the Kypros Nikolites, the rate of preterm birth was quite similar, about 10% in both group pessary and expectant management. And the conclusion was in singleton with short cervical length, insertion of pessary at 20-24 weeks does not reduce the rate of preterm birth, does not reduce perinatal death or neonatal mortality and morbidity in patients with singleton and short cervical length less than 25 millimeters. Let's put everything together. Sacconi did this and published in the Journal Ultrasound Medicine in 2017.
I don't want to interrupt your nice presentation, but I think time is getting over.
If you give me 2 minutes and I finish the presentation.
Okay, go ahead, please.
So the primary outcome demonstrates that spontaneous preterm birth, less than 34 weeks, and the conclusion was pessary doesn't reduce the rate of spontaneous preterm birth. Just a few weeks ago, we had another meta-analysis with 12 RCT, more than 5,000 patients, more than 7,000 fetus or infant, and the conclusion was, pessary does not reduce the rate of preterm birth, neither improve perinatal outcomes in singleton or twins with short cervical length. And now we have a couple of studies that mix pessary and progesterone. In progesterone, women who had pessary and did not receive progesterone, or patients who had pessary and received progesterone, the numbers was quite similar, and pessary was not improved by the addition of progesterone. And the conclusion was, at the point now, cervical pessary doesn't prevent preterm birth, nor improve neonatal outcome in singleton gestation with short cervical length. And our conclusion is, for the prevention of preterm birth in asymptomatic patient, we have 3 groups: prior history, twins, and short cervical length at 2nd trimester. In the first group, cervical assessment for reassuring pregnant women and progesterone. Micronized progesterone, 200 milligrams daily till 34-36 weeks. Twins and select twin gestation, the only thing we should do is cervical assessment. And of course, avoid twins. Instead of 2 eggs, 1 egg. And if I found patients with short cervix, I can use progesterone, 200 milligrams daily, or 200 milligrams twice a day from the find of short cervix till to 34-36 weeks. And finally, patients with short cervical length, less than 25 millimeters, progesterone, micronized progesterone, 200 milligrams daily until 34, 36 weeks. Thank you. Sorry to take long, but it's very difficult to put everything in a short time. Sorry for that.
But you did it, Eduardo. Thank you very much for your nice presentation. Now, I would kindly remind audience that you can send your question or comments via our box during speech. I want to remind it. Now, it is second speaker is Professor Karl Oliver Kagan from Germany, Tübingen, University of Tübingen. Before inviting him, I want to read his brief CV. It will take, of course, too long time because he's a very successful physician. After presenting MD thesis 2004 in Tübingen University, he accomplished residency duration from 2002 to 2009. During this time, he was also in with Professor Kypros Nikolaidis, as a research fellow in King's College Hospital, London. And 2007, he got a diploma in fetal medicine from the Fetal Medicine Foundation, London, UK. 2009, consultant, he became consultant in obstetrics and gynecology. Habilitation PhD in obstetrics and gynecology, development of first trimester screening algorithm for trisomy 21, 18, and 13. 2015, he has a Master of Business Health Administration, another diploma. 2017, he was offered for a full and lifetime professorship for obstetrics and perinatology at the University of Ulm, but he was appointed as full lifetime professor for perinatal medicine at University of Tübingen, Germany. From 2019, he has been working in this institute. Karl Kagan, Professor Kagan, has a degum. If he can express it, Deutsch.
Degum.
Ultraschall medicine.
In medicine, yes.
Medicine, I think I expressed
yes.
it, which you explain later maybe. This is a very important association in Germany, I know. So he is a member of this association in level 3. Research interest, screening for chromosomal defects, combined use of cell-free DNA and ultrasound, risk assessment of for adverse pregnancy outcome, stomatovirus infection in pregnancy. Other involvements, head of DEGUM, section obstetrics and gynecology. This is very important degree, I think, involvements. Member of the International Gen Diagnostic Committee, editor of ultrasound in obstetrics and gynecology, and archives in obstetrics and gynecology. Karl, I think I tried to finish your diploma and titles. Now it's your turn. Thank you very much. Thank you.
Well, thanks a lot for the introducing words. It's a pleasure to give this talk about screening for chromosomal defects. And well, let me start by looking backwards. And I think we've gone a long way towards where we are today. We started about 40 years ago, and there to that time, maternal age was the matter of fact. And we had detection rates for Down syndrome of about 50%, for a false positive rate of 20 to 25%. We then came to biochemical screening, combined screening in the 90s, and now we're at the level of Selfie fetal DNA screening. And if we just look to the figures, well, I think there's no doubt that the the ideal screening has been done by Selfie fetal DNA screening. Look to the Cochrane data compared to the data from the FMF, and you see detection rates that are better than with combined screening, and especially the false positive rate is a completely different word. On one side, you've got the false positive rates of 3 to 5%, and then with the Selfie fetal DNA approach, you get to false positive rates of about 0.1, 0.001%. So it's a different level. But you know, we are not just looking for Down syndrome and not just looking for common trisomies. There are plenty of other things that we need to take care of. It's the common trisomies are always the tip of the iceberg, and everyone sees the common trisomies, but there are fetal defects, there are genetic syndromes, there's preeclampsia, IUGR, preterm delivery, gestational, etc., etc. So many more things that we need to take care of, and it's our task to put it in the right way and to stratify the risks. And just to give you an idea about the risks, look here, the frequency of complications of a 35-year-old woman. And you see trisomy 21, 18, 13, well, they cover about 0.5% of problems. So with microdeletion, microduplications, it's another 0.4%. But then if we get to fetal defects, preeclampsia, we're already at 2%. Growth restriction 5%, preterm delivery 10%. So yes, Selfie fetal DNA screening works perfectly right, but it works for a minute fraction of problems. And if we just focus on chromosomal defects, well then let's have a look to the distribution of risks. And you can see here the risks for chromosomal defects from a 20-year-old up to a 40-year-old. And of course, the risk for trisomy 21 goes up. And of course, it's also the case for trisomy 18, 13. But remember that there are other chromosomal abnormalities. There are sex chromosomal abnormalities. The risk is more or less stable. And especially there are other microarray or rare chromosomal abnormalities. And look, they're also stable. They're at a level of 1 in 270. With other words, the risk of a 20-year-old is certainly not 1 in 1,000. That's the risk of Down syndrome, but her risk for chromosomal defect is 1 in 120. And it goes up to 1 in 40 for a risk of a 40-year-old. And we need to take these things into account when counseling for chromosomal defects. So if we ask ourselves, what's better, Selfie fetal DNA screening or first trimester combined screening, then it's certainly not the right question. It's the combined use of both that matters. And the combined use of both, that always starts with ultrasound. And you look to the baby in a detailed way. And if you see fetal defects, or if the nucleus increased, well, then you're not in a screening fashion. You're not work for screening anymore. It's diagnostic. You need to see what's really wrong with this baby and what's the prognosis. And if the baby looks completely normal, the nucleus normal, well, then carry on with Selfie fetal DNA screening. You already know that the risk for chromosomal abnormalities is low, but then get the final reassurance by using Selfie fetal DNA screening. And let's start with the first arm, with fetal defects. Now, why don't you go for Selfie fetal DNA screening in these situations? Why just take blood and you know what it is? Because there are many more other problems than just Down syndrome, especially in these cases where you see fetal defects. If we look to all structural defects, then about 10% of them do have chromosomal abnormalities. And if you look to the distribution of chromosomal abnormalities in these cases, then you see that about 50% have Down syndrome. There's another 30% with trisomy 18-13, another 10% with Turner's, and then there is a 10% chance of other things. And these things, they get more and more the more tests you use. With this distribution, only cytogenetic was used, but nowadays we talk about whole exome sequencing and this distribution of other things that gets bigger and bigger. And let me show you that with 4 simple examples, 4 things that you can always identify with the first trimester scan. Let's talk about holoprosencephaly. The chance or the risk is about 1 in 3,000. 80% will be chromosomally abnormal, 60% got trisomy 13, but about 3.5% got other chromosomal abnormalities that cannot be identified by using Selfie fetal DNA screening in this situation. You may think, well, who cares? Because the prognosis is bad in any case. Why should you use additional tests? Well, there is a certain risk of recurrence in some of these cases. And especially with these others, there's a much higher risk of recurrence than with trisomy 13. But let's go back to the next, or let's go forward to the next one. Exomphalus, 1 in 400, 40% risk of aneuploidy. The majority will be trisomy 18, but there are, again, 5% other things that need to be taken into account. And it gets even more obvious with these cases with megacystis, especially if the megacystis is between 7 and 15 millimeters. It's not that rare as holoprosencephaly. 20% are aneuploid. The majority is trisomy 18, 13, but there's a fifth of the cases with some other chromosomal abnormalities that can only be identified with a proper setup, with a proper follow-up. And again, the same is true here with increased nuclear translucency, more than 3.5 millimeters. 50% are chromosomally abnormal, 50% is Downs, and 5% are others. So if you see these defects, don't worry about the risk of miscarriage. It's extremely low. And in fact, in the most recent updates, you see that there is no significant chance or no significant risk for miscarriage with amniocentesis or CVS. Go for it. And don't worry too much that there may be a risk of miscarriage. Clarify it properly. And the question is not whether you should do amniocentesis or CVS. The question is which genetic test is the right one. For nowadays, it's cytogenetic, but microarray is everywhere available. And we now talk about whole exome sequencing. And actually, we even talk about whole genome screening or whole genome sequencing in these cases. And have a look here in the lower part of my slide here. What does each of the tests bring, or how does each of the tests increase the overall detection rate for chromosomal abnormalities? Microarray for increased nuclear translucency, plus 6%. Microarray with one structural defect, another 6%. Multiple defects, 9%. Whole exome sequencing, 6 to 80%. So in Tübingen, we do it that we start with cytogenetics, we do the microarray analysis. If we haven't found the anomaly and we know that there's a chromosomal abnormality because the cases look strange, then we carry on with whole exome sequencing. And we've got a detection rate of about 50%, or an additional detection rate of about 50% with whole exome sequencing. And even with cases where only the nucleus increased and you think, well, it should be okay, there are no structural defects. Look to the proportion of additional copy number, pathologic copy number variants that you find with microarray analysis. Let's go for the reference of less than 3 millimeters. There was 1.7% pathologic copy number variance. And from 3 millimeters on, there was a massive increase. So 3 to 3.5 millimeters, 6.5%, more than 3.5 millimeters, up to 14% chromosomal abnormalities that were only picked up with microarray analysis. So it's very clear in these cases where the nucleus increased of more than 3 or more than 3.5 millimeters, offer microarray analysis in addition to the normal cytogenetic analysis. So now we spoke about this side of fetal defects and how to clarify. Let's think it through. If you find a normal anatomy, what to do next? Well, we thought of two different approaches. One approach is to look for, to do a normal first trimester scan. And if you find a normal first trimester scan, combining the nucle with biochemistry, and if the risk was increased, well, then it's time to do a CVS. If the risk is extremely low, it was time to do nothing anymore and go for the 20-week scan. And if you were in between, well, then it was previously time to assess the nose bone, the tricuspid, and the ductus. Now it's clear that it's the self-reveal DNA test that matters. And actually, both ways are okay. Here's a study that came from Denmark, and they compared both ways, classical combined screening together with a contingent approach. And you see detection rates, they're both okay. They were both 100% because the numbers were small, but what matters is the false positive rate. It was 3% on one side with classical combined screening and just 1.2% with a contingent approach where you do a Selfie fetal DNA test only in the middle arm. We wondered whether it could be slightly different in a way that I've shown you just now, where you start with a ultrasound examination and you directly go for invasive testing for the ones with fetal defect or increased nuchal, and for the others you carry on either with Selfie fetal DNA screening, and we compared it with classical combined screening, and the results were very obvious. On the left side here, that was the arm that we examined with combined screening. And on this side, it was the arm where we did the ultrasound examination followed by Selfie fetal DNA screening, and the risk distribution speaks for itself. And if you look to the false positive rates, and this was the main focus, the false positive rate with combined screening was 2%. Remember, we eliminated that 1% increase NT straight away. And with a combined use of Selfie fetal DNA screening together with ultrasound, we didn't have a single case of single false positive case anymore. And that was nicely reflected in the overall invasive testing rate. In one arm, in the classical combined arm screening, it was 1.7%. And in the other arm, there were only 2 more cases where we used the invasive testing throughout the whole course of the pregnancy. So I think this speaks for itself. So with other words, if Selfie fetal DNA screening is so much better, what can we do to adjust it, and what shall we take care of? And I think there are some simple things that we need to consider. And I only want to highlight, given the short time, I only want to highlight 3 aspects. So first aspect, if you do Selfie fetal DNA screening, don't forget the fetal fraction. With decreasing fetal fraction, the overall detection rate goes down because at the end of the day, in behind of your person, the risk that you get, there are set statistics. And the lower the fetal fraction is, the lesser the differentiation between the cases with Downs and the euploid distribution. And that's been nicely shown by Dave Wright, who played it through in a model. What happens if the fetal fraction is 9% or more? Well, then the overall detection is nearly 100%. But if we go down to 7, 6, 5, 4%, you see at a level of 4, detection is far away from these 100%. It's about 60%. So with other words, have a look to the fetal fraction and react on the fetal fraction. Next one. If you find no result, if you've got an inconclusive result, watch out, because inconclusive NIPT results, they need further clarification. There are a lot of more chromosomal defects in these cohort, especially trisomy 13, 18, and triploides. And again, nicely shown by the group of Professor Jinekoloji, and they look to the proportion of cases with a chromosomal abnormality that ended up with an inconclusive result. And you see with trisomy 21, there was 1.9% of the cohort with an inconclusive result. With trisomy 18 and 13, it went up to 6 and 8%. So watch out that there's not a chromosomal abnormality if you don't get a final result. And the first thing that you do is you go for a second blood sample. And again, a study from Professor Jinekoloji where they looked to 300 cases with no results. And about a third had redraw, okay? And with that redraw, they clarified 2/3 where they got a final result. But before doing this, before taking a second sample, have a special look, to have a detailed look to that fetus, because with trisomy 18 and 13, you will see that fetus with a chromosomal abnormality. So don't go for a redraw without assessing the anatomy properly. Go for the ultrasound examination first. Watch out if there are any signs of trisomy 13 and 18. And if no, then go for redraw And if you see these chromosomal abnormalities, if you find defects, go for invasive testing rather than for a second blood test. And, you know, let me go back once again to the slide that I've shown you just before. And I've shown you already that if the nucleus increased or if you see fetal defects, go for invasive testing. But there's another hint in this slide that is very important. What happens if you redraw, if you take blood again, and for the second time, you don't get to a final result? Well, at the end of the day, the patient will ask you for an invasive test because you can't clarify the situation anymore. And that's why we recommend to take an additional blood sample, a serum sample at the time where you do selfie fetal DNA testing in the first go. And that will be at about 11 to 13 weeks, and just freeze the sample, okay? And if you do the first go, if you do your first analysis for cfDNA screening, you do this, the ultrasound examination, you go for the second blood sample, and you still don't get to a final result, then you can still take this serum sample that you've got in your fridge, do the analysis on PAP-A and free beta and free beta HCC, and then go for a combined test just to clarify the situation. And that sorts out these remaining cases where you don't get to a final result. There are plenty more things that I could talk about, but time is flying. So I'd like to come to an end. Think about the different options. Don't focus too much on trisomy 21, but think about it in an overall setup where there are many more chromosomal abnormalities, where there are many more problems than just chromosomal abnormalities. Do the ultrasound examination properly. Don't forget to counsel the patients on their request, or not on their request, but on their needs, okay? Then take blood, and I'm sure then it will be sorted out. Thanks a lot.
Mr. Kagan, thank you very much for your nice presentation. Really, thank you very much. Now, I want to invite a third speaker, Professor Serdar Ural from the States. Now, I'm trying to read his CV. After graduating from Ankara University Medical School, now I'm trying to focus on the he moved to the States, research fellowship in perinatology, Georgetown University School of Medicine, Washington, and chief resident in Obstetrics and Gynecology, State University of New York School of Medicine, Syracuse. Postgraduate fellowship in maternal fetal medicine. Medicine Department of Obstetrics and Gynecology, Baltimore, and leadership development for physicians in academic health centers, the Department of Health Policy and Management, and the Center for Continuing Professional Education, Harvard School of Public Health, Boston. This is the education position. Business now, he's working in the Penn State University College of Medicine, Department of Obstetrics and Gynecology, Division of Maternal Fetal Medicine. The important thing that his academic and teaching appointments, he's professor with tenure, physician scientist, track Department of Obstetrics and Gynecology, the Pennsylvania State University College of Medicine, Pennsylvania, Director, Division of Maternal Fetal Medicine, Department of Obstetrics and Gynecology, Pennsylvania State University, Director, Maternal Fetal Medicine Fellowship Training Program. So he's the, I think, most important title is a professor with tenure. It's very important. So I am very proud of inviting him, making his speech. Mr. Roth, please. This topic also is very interesting topic because, you know, the number of cesarean section is going up, and related to this increase in cesarean section, we have many terrible in placental invasion anomalies. So we will get, I think, very good information from Dr. Ural. Please, Mr. Ural.
Yeah, akşamlar. Good evening, good day. I would like to thank Professor Faik Koyuncu for inviting me. I would like to thank the Turkish Society of OBGYN, the Tjod, for inviting me as well. And thank you for your very kind introduction. I'm going to try to briefly review with you placental insertion anomalies, which nowadays, at least in the United States, is called the placenta accreta spectrum. Okay, here we go. So at this point, the placenta accreta spectrum involves the old nomenclature that includes placenta accreta, placenta percreta, and placenta accreta. And the placenta accreta is defined as an abnormal trophoblast invasion of part or all of the placenta into the myometrium of the uterine wall. And like I said, the accreta spectrum was previously known as accreta, accreta, percreta. In the United States, there's about the placenta accreta spectrum is seen in about 1 in 270 births. And here you can see on the left side, a normal placenta with a normal echolucency and the myometrium beneath it, which shows a normal appearance of a placenta. And on the right side, again, you see a placenta. You can see normal echolucency, or the Nida-Buck layer in pathological terms, and the uterus in very fine distinction. And this is another normal placenta. Okay, 1 minute. And then here, you can see the myometrium, and you can see the placenta here. And pathologically, you can see the fibrin deposit, which is the Nida-Buck layer. Here, you can see a definitely abnormal placenta where it is very difficult to define an echolucent area or the Nida-Buck layer. It is very difficult to define where the myometrium of the uterus is. And all you see is kind of all placenta. And even this placenta does not look normal. And what is the abnormality of placenta accreta spectrum? It is the fact that on ultrasound, you see vascular lacunae, such as here, and you see the loss of the normal hypoechoic zone, which I just mentioned. It is very hard to define where the myometrium is, where the placenta is. And even if you do see myometrium, it is probably very thin enough that it is very difficult to identify by ultrasound. And you can see the placenta kind of extending into the myometrium and maybe even further into the other tissue, such as on this slide. And when you apply color Doppler flow, and this is another view of that abnormal placenta, this is a case that we had. If you apply Doppler, you can see that there's definitely abnormal vascularization at the bed of the placenta. And the definition of abnormal means that there's turbulent lacunar flow which is the most common finding on ultrasound on placenta accreta. So you can see that the flow here looks kind of normal. This is a vessel. It looks kind of normal here. But when you look at the placental bed, the flow does not look normal and it looks disrupted, which gives the turbulent lacunar look that you would find in a placenta accreta spectrum patient. Now, the placenta accreta spectrum has been increasing because the number of cesarean sections has been increasing historically. And we all now know, based on, even though there's no randomized trials, that really the primary diagnostic modality for diagnosis is obstetrical ultrasound. And that is really the best way to diagnose such an abnormality. Mostly the accreta spectrum is diagnosed in the second and third trimester. The sensitivity of ultrasound, depending on what you read, is between 50 and 90%. In good hands, it's very high. The specificity is about 70 to 95%. So in good hands, experienced hands, it could be high. And this image gives you a good experienced view where you can probably comfortably say this is an accreta spectrum and make a diagnosis. And the fact of the matter is, do we need MRI? There are places that do MRI, we don't, because literature does suggest that MRI should not be used as a primary modality to diagnose, and it is unclear whether MRI improves the diagnosis. So therefore, we usually do not obtain MRIs. There are places that do, and that's fine. But the bottom line is the best way to diagnose is using ultrasound modality. Now, if we look here, this is this patient on pathology. Here, you do not see a fibrin deposit layer like we saw before, a clear defined line of where the placenta is and where the myometrium is. So this is the myometrium area, and this is the placenta area. And you can see villi or trophoblastic cells invading into the myometrial area. So this is an accreta, as you can clearly see, where you do not see the nitabuc layer or the fibrin deposit that you would normally see defining a clear line. It does not exist. The villi has been extending through the myometrium, and this is a accreta pathology, which is what we found in this case that we had. This is another ultrasound, another case of placenta accreta syndrome. As you can see here, this is the cord insertion site. This is the placenta. And then when you look here, it's kind of unclear as to, okay, where's the line that is defined between the uterus and the placenta? And it does look suspicious, not maybe the best view, but it does look suspicious. And you have to understand that there are more obesity pregnancy patients, especially in the United States, where ultrasound may not really give the best view on some instances. So here we have a suspicion. So when we apply Dopplers, this is the placental bed. Here you can see disruption of the flow. It is very turbulent looking, and it doesn't look very well defined as the cord insertion, and it looks mixed up. So this is, again, another potential finding of placenta accreta syndrome, where, okay, the initial ultrasound, okay, we're suspicious, we're not sure if this is good or not. Then you apply Doppler, and you can clearly see that this is not a normal finding, so it needs further investigation. This is another view, another patient that we had, placenta, no history of C-section or surgery. So everything is kind of looking good. You kind of see an echolucent area here. Here, there looks to be like some suspicious lacunae, which, you know, does not look like your classical round appearing lacunae. So further investigation, which we always do now in every placenta, you see that you apply Doppler and you see kind of disruptive formations here and more vascularity than you would suspect in the placental bed. So when we were looking at this patient, and unfortunately not all Accreta looks classical and traditional on your ultrasound examination, so you have to be suspicious. And when you're suspicious and you're not sure, we usually bring these patients back once a week or every week, and we follow them very closely. There's no guideline as to when the patients have to come back for follow-up ultrasound, but once we get a suspicion or a diagnosis and they're going to continue with the pregnancy, we bring them back every week. So this patient, we brought back next week, a week later. A week later, this is what we see. Again, placenta. There looks to be, again, some suspicious formations here. You know, we're thinking, okay, this kind of looks like a formation of, is there Accreta spectrum? The myometrium here looks less defined because we see bladder here, and this is a transvaginal ultrasound. And we can't really define the myometrium, and we see bladder kind of close to the placenta. So then we apply Dopplers, and this is a reverse angle view, and voila, you see placenta, again, these kind of like suspicious looking lacunae, the bladder, and then when you apply Doppler, you see all this vascularity, and it is right between the placenta and the bladder, and myometrium is really hard to define or is not seen. So this is another classical view of a placenta Accreta spectrum. Now, in this case, in old terminology, this is probably Parcreta or Increta, and you will only know that once you operate on the patient. So this patient was taken to surgery. We operated on her. Unfortunately, the placenta was invading into the bladder. So we had to do a hysterectomy and a bladder resection. There was a lot of bleeding, even though we tried to not touch the placenta. There was uterine atony. It didn't respond to medications. The patient did well, but we had to do a hysterectomy. The baby was born prematurely, but did well and grew. But this is the classical view of a placenta accreta where placenta looks kind of not normal. You bring them back, and then you see the structure. So being suspicious is really important to be able to diagnose placenta accreta spectrum on ultrasound. Now, when these patients don't need to be delivered, like I said, we bring them back once a week to follow up on ultrasound. And we're happy we did this in this case because it got worse and she ended up delivering. If this happened at home, she could have died. So we prevented a maternal death, in my opinion. The range for delivery, if it can wait, is after 34 weeks. So 34 weeks to 37 weeks is when we try to deliver these patients. We really don't let them go beyond 37 weeks because of risk of bleeding and dying from such an abnormality. So in the end, by conclusion, the best way to diagnose placenta accreta spectrum is by ultrasound. It is unclear if MRI is useful. The papers that show MRI is useful are biased because these are the patients that had an abnormal ultrasound and were sent to MRI. So their pickup rate or diagnosis rate is going to be higher. But the American College of OBGYN and Society of MFM do recommend ultrasound as a primary method of diagnosis. If you're suspicious and not sure, you bring them back in a week. You have to have experienced eyes looking at them, you can have a colleague take a look at them. But in the end, these patients, if they're not acute, need to be delivered between 34 and 37 weeks. Thank you very much. And I appreciate again your kind invitation, Professor Faik Koyuncu.
Thank you very much, Professor Ural, for your really nice presentation. I think we have some questions about this disease, Accreta, because this is going very worst right now in the world, I think. Now, I open discussion of comments. I have two questions for Fonseca. One from India. Mukul, you have many powerful articles related to prevention of preterm birth. You have you show us effectiveness of vaginal progesterone, especially short cervix. What do you think about vaginal progesterone for women with a history of preterm birth previously?
Yeah, it's a good question. I think we need to take into account what preterm birth means. First of all, we need to understand if it was a prior history of spontaneous or medically indicated preterm birth. So secondly, we need to understand if it was early, less than 34 weeks, or between 34 and 37 weeks. So what's the management for this kind of patient? In my point of view, if the patient had a prior history of early preterm birth, less than 32, 34 weeks, spontaneous preterm birth, I will start progesterone by 200 milligrams daily, and I'm going to check the cervix from 14, 16 weeks up to 24 weeks. If the cervix is still good, it's okay. If the cervix is shorter than 25 millimeters, I'm going to discuss with her the need of cerclage. So I do both progesterone and cervical assessment. They need to go together. I think, is it clear? The answer?
Yeah, it's clear. I open my microphone. So, Fonseca, we have second questions to you also. Just a second. What do you think about the use of progesterone in patients with cerclage? And also, I want to add one more question. How do you consider patients to give progesterone if you use vaginal route?
Yeah,
how do you consider this kind
Let's
of?
Let's start by the route. I think that is well demonstrated that the vaginal route is the best route for progesterone. Firstly, because there are less side effects, and secondly, because there are the first uterine pass, and there are some papers demonstrate that the level of progesterone in the myometrium and in the endometrium is higher compared to other roads. So it's better vaginal, there is no doubt. Secondly, I need to understand that the cerclage has the clear indication for cerclage is cervical insufficiency. So you have the historical indication for cerclage that it's 2 or 3 pregnancy loss over than 12 weeks and less than 22 weeks, okay? Or those that are ultrasound indicated cerclage. So if there is a clear diagnosis of cervical insufficiency, cerclage by itself, it's enough. The main problem now, when you talk about prevention of preterm birth, is that there are a few cases that I'm not able to do a clear differentiation between short cervix and cervical insufficiency. So because this, for those patients with prior history of early preterm birth, let's see, less than 28 weeks, there is a higher chance of cervical insufficiency, but I'm not tell you 100%. So maybe in this case, I'm going to start with progesterone and I'm going to follow the cervix. If the cervix gets shortened, so, and there are some papers that demonstrate that when the cervix is less than 10 millimeters, circlage is a good management. But in this special case, when I'm not able to do the differentiation between clear cervical insufficiency and risk of preterm birth by the short cervix, in this case, if I use circlage, I still with progesterone because I think is safer for the patient. This is in the only case. If I perform my circlage between 12 and 16, 18 weeks for cervical insufficiency, or I have a clear diagnosis of cervical insufficiency, I just do circlage.
Thank you, Fonseca. Before Professor Kagan, because it's very related to progesterone use, I would ask to, Professor Ural. A question came from Izmir, Turkey. In the USA, 17-hydroxyprogesterone is frequently used for the prevention of preterm birth. However, some new article says that 17-hydroxyprogesterone increasing the risk of gestational diabetes. For that reason, in respect with this effect, is there any change in the treatment methods in the USA?
Yes.
Professor, please.
17-hydroxyprogesterone was being used frequently, but not anymore because of the GDM side effect. And the FDA has sent out a note cautioning the use of 17-hydroxyprogesterone. So really, recently, this year, we've only been using vaginal progesterone for preterm labor purposes.
Thank you. Professor Kagan, I think this is for you from Deniz Kulaksız. Where is it? Why do not we take anti-cutoff as 3 millimeter instead of 3.5 millimeter? Thanks.
Well, thanks a lot for the question. Whether it's more a logistic question, you know, if you can afford going for all these kind of investigations from 3 millimeters on, which covers about 1.5 to 2% of the population, I think it's reasonable to go for it. But if you need to restrict the examinations due to financial aspects, certainly 3.5 millimeters is the cutoff to go for.
Very much.
I hope this answers it.
And there is another question again from Turkey after congratulate us. Pregnancy with isthmocele. Do you need to terminate this kind of pregnant woman pregnancy?
Could you repeat the question?
Pregnancy with isthmocele. Isthmocele, you know? Isthmocele.
What is it?
After a niche from C-section incision.
Now I got you. Yeah. Low insertion. Well, you know, in general, we terminate it. It depends where they're placed. And these are the procedures of all kind of abnormal placentations. So if they are really within the scar, well, then we terminate these pregnancies. We don't let them go. If they're a bit higher, if we do have the feeling that they could develop within the or into the uterus, we wait and see for another week and compare what happens. But at the end of the day, if there's any doubt, we terminate these pregnancies.
Do you have any comment from other lecturers?
No? Yes, I agree.
Okay.
Usually cesarean section scar or lower uterine segment pregnancies in a prior C-section patient, if you wait long enough, they will turn into placenta accreta syndrome, and it could be deadly. So I agree with Carl Oliver Kagan that they probably should be terminated.
Okay, thank you. Professor Ural, you explained very clearly, but I want to ask again, do you have any special team to greet this kind of patients, pregnant women with Accreta or Accreta, Accreta? Do you have any group or team in hospitals in the States?
Yes, usually places do. But even if you don't, you know, as a perinatologist, you should be able to perform or know how to perform a hysterectomy, a cesarean hysterectomy. If there's spread into the bladder or the colon, you would have to call urology or urogynecology. You would have to call general surgery or gastrointestinal surgery to help you with the repair of the defective organs adjacent to the uterus. So if you have a team, those would be the key players. But if you don't have a team, those would be the two people that you would most likely need to call.
Thank you. Now in Turkey, we recommend our colleagues working in some urban area. If you see this kind of patients, if you start to operation C-section, please take the baby from fundal side, and after close to uterus, leave the placenta inside of uterus, and after that we accept these patients into our clinic. We use methotrexate, and maybe 3 or 4 months later, many pregnant women, placentas are resolved, and maybe with a small, very basic, simple DNC has finished the all procedure. But I think 2 or 3 patients out of 18, I think, we need to operate them because she was excited. She doesn't want to wait for a long time. We did a hysterectomy. Even 3 days later, if we do perform a hysterectomy, it is easier than the meanwhile doing cesarean section. What do you think about that? But I think there is no literature right now with that.
I think that's very interesting, and you are correct. There's really no literature. So I think you and your group should publish that. That would be very informative.
Okay, the last. I think we have finished the time. Thank you very much for your great contribution. I learned many things. Thank you very much. I think, I don't know how many countries joined us, but some other countries joined us, and more than 250 participants joined and made questions or comments, etc. Thanks also for all audience a lot because they were with us. But I'm really proud of your joining with this webinar in the name of my colleagues in Turkey, at least. Thank you.
You're welcome. Thank you. Thank you for the invitation.
It was a pleasure to take
part. Thank you.
Thank you, Prof.
Thank
Bye.
you.
Ciao.
Thank you.
Have a good time.
Bye-bye.
Have a good
Have a
day.
good time.
Bye.
Bye-bye.
Thank you.
Good evening.
Have a nice summer.